Hi, everyone. I wish we could be in person, and hopefully someday we will for this conference. But Dr. Monk and I are very excited about presenting updates on antibody-drug conjugates and talking about exciting data on efficacy and safety. I'm Ursula Matulonis, medical oncologist at Dana-Farber, and I run our division of Gynecologic Oncology here. And you'll also be hearing from Dr. Monk after my talk. I'm going to be talking about antibody-drug conjugates in ovarian cancer, and Dr. Monk will talk about cervical cancer as well as endometrial cancer. So I just want to talk about the basics, ABCs of antibody-drug conjugates. This is one of the ABCs and how these drugs are constructed. So on the left, the ADC is comprised of three parts. One is the antibody, which looks like a big Y. And that antibody is linked to a drug, and that drug is in red. There are different drugs, topoisomerase 1, duocarmycin, and microtubule payloads. And that antibody recognizes a target. And on the right, you'll see examples of ovarian cancer targets that are being used to develop ADCs that are in clinical trials and that are kind of coming down the clinical trial pike. So the ones that you probably have heard of mostly are folate receptor alpha or FOLR1, HER2, but there are others. And these are in no particular order of importance, but these are ones that are in clinical trial testing, either from phase 1 through phase 3 clinical trial. So NaPi2b, CDH6, B7H4, B7H3, TROP-2, mesothelin, MUC16, PTK7, just to give you some of the examples. And that target is present on the cancer cell. So that's how the ADC works. Simply is that the ADC recognizes a target that's sitting on the outside of the cancer cell and is able to enter the cancer cell through that target, and those targets are listed on the right. And then, as the cancer cell is being killed and broken apart, that drug has access to other cancer cells in the environment. And maybe even then, cancer cells that don't have the target have that drug right next to it and can hopefully kill that target or that cancer cell as well that may not have the target. I also mentioned the drug antibody ratio, or DAR. You'll hear about that as we talk about different antibody-drug conjugates. It's the average number of drug molecules or drug kind of particles that are attached to each antibody-drug entity or molecule. And everyone thinks, oh, well, higher is better. It may not be the case because antibody-drug conjugates each have different kind of work a little bit differently. Some need a lot of target on the cancer cell, and some actually don't. I'm going to start talking about Mirvetuximab because that was and is the first antibody-drug conjugate that was fully FDA approved for recurrent ovarian cancer. This drug is an ADC that's comprised of FR alpha or folate receptor alpha, FOLR1, those are all names for the same thing, a linker that links the antibody to the drug. And this is the drug called DM4, which is a tubulin target agent. So it disrupts cell division. The drug antibody ratio here is 3.4. So just more informational than anything else. We know that FOLR1 or FR alpha has very limited presence on normal tissues, which is a good thing because you don't want the antibody-drug conjugate targeting normal tissue. But it's elevated in most ovarian cancers. All of the initial testing of mirvetuximab was done in high-grade serous ovarian cancer, but we're learning that other histologies also have high levels of folate receptor alpha. The phase 1 testing started, believe it or not, back in 2012. So it's taken, nearly a decade to get this drug from phase 1 testing to the point of an accelerated approval in 2022. And 6 milligrams per kilo was selected as a recommended dose to use, and we'll talk a little bit more about that. Lessons learned, so over that decade of drug development, is to use an adjusted ideal body weight. So that's different than some of the other ADCs. So you use actual weight that can increase the risk of lung toxicity. So we use something called adjusted ideal body weight. And some of the earlier phase 3 trials of mirvetuximab were actually negative, but the different assay to test for folate receptor alpha and different cutoff has led to approvals. The accelerated approval of mirvetuximab happened with the SORAYA study. This was about a 100-patient trial, all high-grade serous patients with recurrent disease, up to 3 prior lines of prior therapy. And all these patients had received prior bevacizumab. The primary endpoint here was response rate, as assessed by us as the investigator. And then the key secondary endpoint was how long the response lasted for. And that's called the duration of response. And the starting dose here is 6 milligrams per kilo. The results were certainly significantly better than one would expect with single agent non-platinum chemotherapy. So here the overall response rate, that's what that stands for, is about 32%. And the median duration of response rate was about 6.9 months or about 7 months. And this drug works quickly. So about 2/3 of patients showed a response if they had a response at the time of their 3rd cycle. The main side effects are eye side effects, neuropathy, fatigue, and gastrointestinal side effects. The ocular toxicities of mirvetuximab, or ELAHERE, that's the other name for it, but I'm going to say the real name of mirvetuximab, occur because of off-target effects of DM4, that's the payload on the ADC. It disrupts the early stem cells on the cornea. Those early stem cells then actually move into the center of the cornea and develop and lead to microcysts. The most common adverse events are just blurred vision or some visual impairment, keratopathy, and that's what the ophthalmologist or optometrist sees on eye exam, dry eyes, cataracts even, photophobia, meaning sort of if you look at the light, it's painful, and then eye pain. And the eye side effects can occur pretty quickly, about 1.2 months into starting treatment. The eye exam needs to be done before starting mirvetuximab every 2 cycles through the first 8 cycles. And the eye exam can be done by an optometrist or an ophthalmologist. A lot of people don't necessarily have access to an ophthalmologist. And that box on the right is a black box warning that really says, yeah, you got to pay attention to the eye exam. This lists, and I'm not going to go over this too much, but basically there is a proactive management to try to prevent the ocular events using topical corticosteroids on the eye and lubricating eye drops to keep the eye from becoming too dry. And we give our patients prescriptions for these eye drops to be taken before and during their infusions, those first few days of the infusions. And it's really important to avoid the use of contact lenses. This is the example of the eye form that I tend to give my patients. This is off a website, and the optometrist or the ophthalmologist fills this out. And we as the oncologist make that decision based upon the FDA package insert if somebody can actually continue on with mirvetuximab or not. So if the eye findings or eye symptoms are significant, sometimes we'll hold a week and then dose reduce. So that's really important to be in very close contact with the eye specialist. This is taken from the FDA package insert. The starting dose is 6 milligrams per kilogram. The first dose reduction is down to 5, and then you can go down to 4. Reasons for the dose reductions are mostly because of neuropathy as well as eye side effects. What this drug does not have as side effects is hair loss. There's no hair loss, and blood count drops really do not occur. And if you're interested in how the adjusted ideal body weight is done, it's at the bottom here. In November of 2022, the FDA granted accelerated approval based upon all those reasons on the right. Really, there was an unmet need for effective therapies for platinum-resistant ovarian cancer, and there was sufficient data to allow us to use this drug prior to the full FDA approval. The full FDA approval occurred because of the study Mirasol. This is a randomized phase 3 study that randomized patients, very similar eligibility criteria that had with SORAYA, except prior bevacizumab was optional. So here patients were randomized to either mirvetuximab or an investigator's choice chemotherapy, and that's either weekly paclitaxel, liposomal doxorubicin, or topotecan. Here, the primary endpoint is progression-free survival as assessed by us, meaning how long the cancer stays in remission for before coming out of remission, with a key secondary endpoint of survival as well as response rates. So these results really showed that Mirvetuximab had superior results compared to chemotherapy regarding the amount of cancer shrinkage or overall response rate, the time in remission or progression-free survival, that's the other name for that, and then overall survival. So women lived longer if they got Mirasol compared to single-agent chemotherapy. The side effects were different. So I've already mentioned the side effects of Mirvetuximab are mainly eye toxicities. That really doesn't happen with chemotherapy. And then neuropathy and some GI side effects. You also have to watch out, too, for pneumonitis. And that's not as big of an issue as some other antibody-drug conjugates. But when you're getting your cancer reassessed, should involve a chest CAT scan. This is the overall response rate in the Mirasol study. So this is based upon CT scans and measurement scans. Overall response rate, 42% for Mirvetuximab versus 16% for chemotherapy. So a big difference here. So because of that study, Mirasol, publication in the New England Journal, this drug received a full FDA approval on March 22nd, 2024 for patients with folate receptor alpha positive, meaning 75% or higher positivity, meaning looking under the microscope, 75% of the cancer cells stained for folate receptor alpha and in a high intensity staining, 2 or 3 plus. Platinum-resistant ovarian cancer, no histology specified, and then up to 3 prior regimens. This drug starts to lose efficacy if you've been more heavily pretreated, so hence why it's up to 3 regimens. There are other ways of using Mirvetuximab, and I'm not gonna dwell on this too much, but the NCCN ovarian cancer guidelines, these are guidelines that insurance companies actually use to determine payment, but they are guidelines for us as oncologists to determine, okay, is this an okay drug to use in this particular situation? So for platinum sensitive, so remember the Soraya, Mirasol were in platinum resistant, the Piccolo study is in platinum sensitive recurrent ovarian cancer, using Mirvetuximab as 3rd line or greater. And this showed an overall response rate of 52%. And a median duration of response, meaning that how long the cancer stays in remission for about 8.3 months. And so it's not going to get an FDA approval because there's not right now a phase 3 study, but it's on the NCCN guidelines, so we can use it. And then if your tumor's folate receptor alpha is less than 75%, one can combine Mirvetuximab with bevacizumab. And this is the paper that shows this. These are the results. So these are patients who had different levels, 25% or higher, and the response rate here is 44%. And you can see at the bottom, FR alpha greater than 75%, 50 to 74, 25 to 49. There are definitely responses here. It drops down the lower the level, but there is some level of response. I also want to point out another medication that's also targeting folate receptor alpha. It's Rinatabart, sesutecan. It has a different payload than Mirvetuximab. It is a topoisomerase payload and a drug-antibody ratio of 8. These are results that one of my colleagues, Betsy Lee, presented at the Society of Gynecologic Oncology meeting in Seattle in just this year. And this was a dose expansion study for basically randomizing patients with platinum-resistant ovarian cancer to either, we call Rinatabart, I call it Rinatabart, people call it Rina-S, to either 2 different doses, 100 or 120 milligrams per meter squared. And these are the results. So for the 120, which is the confirmed starting dose of this drug, the response rate was 55.6%. And if you had to drop down because of side effects down to 100, there's definitely sufficient activity here. There's stability of disease as well as some responses. Of note, responses, so anti-cancer responses, occurred regardless of the folate receptor alpha level. This is a drug that's being developed, different payload than Mirvetuximab, and you don't have to have that 75%. In fact, you might not even have to have much to get on to be able to use this drug. And a phase 3 study is now underway in platinum-resistant ovarian cancer. On the right bottom here, these are side effects, and the side effects are different because the payload's different. There's some hair loss. There's more drop in blood counts. There's also gastrointestinal toxicities too, but really hair loss and drop in blood counts are the main side effects. I want to move on to HER2, which is another drug that we're using in ovarian cancer, and that's trastuzumab deruxtecan, aka Enhertu. This is an anti-HER2 antibody. So HER2 is another target besides folate receptor alpha, and it has a topoisomerase 1 payload. A lot of the data that has supported the use of this drug in ovarian cancer and other GYN cancers is from this trial called Destiny Pan-tumor HER2. It's a basket trial. This is the trial design. These are the different types of patients' cancers who are enrolled. The top 3 are GYN. Dr. Monk is going to talk about cervix and endometrial. I'm going to talk about ovarian cancer here. So 40 patients with HER2 2+ or 3+. So this is measured, the level of HER2 measurement is different compared to folate. This is a different assay. This is 2+ or 3+. And I've red boxed the ovarian patients. So 45% overall response rate, median duration of 11 months. So very good. And this was also done under a central review. These are the efficacy endpoints. And when you look at the level of HER2 expression, so 3+, the response rates are higher than 2+. And on the right, the 2024, the FDA gave an accelerated FDA approval, tumor agnostic, for HER2 3+ IHC. So 3+ is not that common in ovarian cancer, but it happens. So it's certainly worth checking. And in 2024 also, the NCCN guidelines adopted a 2B recommendation. So most of the time that's accepted by insurance companies to use trastuzumab deruxtecan for 2+ HER2. And there are other HER2 antibody-drug conjugates being tested, which I'll talk about in just a couple of minutes. I just want to point out side effects of Enhertu. It also has a black box warning on the right, but that black box warning is for interstitial lung disease and pneumonitis, so lung changes on chest CT scan. The side effects of Enhertu are, as I mentioned, drop in blood counts, hair loss. So it's a topoisomerase 1 inhibitor, so very much like Rinatabart with a topo 1 payload. You do see myelosuppression or drop in blood counts, some hair loss. And then with trastuzumab deruxtecan, the other name that we call is TDXD, gastrointestinal side effects, diarrhea, nausea, vomiting, and this risk of lung toxicities, which is about 10% and can be significant. The other point I want to make is because of the drop in blood counts, if somebody has had blood count drops in the past, I tend to use growth factor added with the Enhertu. But it's really important that this black box warning basically says, if symptoms occur with the ILD or pneumonitis, you have to permanently stop Enhertu. So because there have been, unfortunately, deaths on the initial studies when this was not taken seriously, or we are learning about the drug. This is taken directly from the package insert. So for grade 1 interstitial lung disease or pneumonitis, meaning like we do as chest CT after 2 cycles, and we see changes, bilateral, pneumonitis, but somebody doesn't have any symptoms. Like, oh, I feel great. I don't know what you're talking about. You have to hold this drug until the lung changes have gone back to 0. And sometimes we use steroids and sometimes not. Sometimes we get our pulmonary colleagues involved. Sometimes we don't, but it's definitely always a good idea to have pulmonary involved because sometimes you may need to use a few week course of steroids. And as I mentioned before, if it's grade 2 or higher, meaning somebody has symptoms, a cough, shortness of breath, you have to permanently stop the drug. And chest CTs should be done frequently. I order them every 2 cycles per the Destiny Pan-tumor HER2 study. Interestingly, these are some of other planned antibody-drug conjugate trials in ovarian cancer. These are upfront. So we're seeing now antibody-drug conjugates here. This is trastuzumab deruxtecan, the drug I was just telling you about, is now opened up in a phase 3 study. for newly diagnosed patients who are finishing up their chemotherapy. I should also mention that there are other HER2 antibody-drug conjugates that are in clinical trial testing right now, really examining lower levels of HER2. So sometimes even 0 or 1 plus as opposed to 2 plus or 3 plus. For second line platinum sensitive, there's a drug called sesutecan turimotecan or SAC-TMT. That is a antibody-drug conjugate targeting TROP-2. And then Mirvetuximab is also in this as used as maintenance after platinum-based chemotherapy for platinum-sensitive ovarian cancer. And then there are also drugs, I also already mentioned Rinatabart, sesutecan, or Rina-S, but there are other medications that are being tested in the platinum-resistant. So these are medications that some of them are, not new, right? And HER2 and Mirvetuximab, but there are others that are that we will likely be using in clinical practice very soon. And these are the other HER2 ADCs that are being tested, I've mentioned before. We have this Systimune drug, BL-M07D1. This is from Duality Bio, DB1303. And then there are two other drugs that are actually in phase 3 clinical trial in China right now for platinum-resistant ovarian cancer. And all of these drugs are topoisomerase 1 inhibitors. And then lastly, it's really important as we're thinking about the use of antibody-drug conjugates in the practice of treating our patients with ovarian cancer, is really thinking about 3 things: toxicities, the biomarkers, and then also antibody-drug conjugate sequencing. So if we're starting off with a antibody-drug conjugate using a topoisomerase inhibitor, is it possible to use another ADC with a topoisomerase inhibitor, possibly with a different target or the same target? Not right now. There are not really many trials testing that, but that's something to think about. But certainly using ADC after ADC, especially if there's a different payload. But also always thinking about toxicities and making sure that we're not making someone's pre-existing toxicities worse. And then also thinking about, proactively managing toxicity, especially the interstitial lung disease, which is a specific toxicity that we see with antibody-drug conjugates, bone marrow suppression, especially seen with topoisomerase inhibitors, and also neuropathy that are seen with the antimitotic antibodies-drug conjugates like Mirvetuximab. All right, thank you so much. I think I stayed on time. It's a pleasure. Hopefully we'll see each other in person. And thank you very much. And I'm going to pass the baton over to Dr. Monk.
Greetings and welcome. Wow, that's a lot to follow. Professor Matulonis, she's very humble, but she has been a leader in bringing these medications to the clinic. I'm here to talk about antibody-drug conjugates. We really have a diverse audience today. I hope that I can provide something for everyone, no matter what your background is, whether you're individually fighting gynecologic cancer, whether you have an acquaintance or family member, or whether you're a physician, or even perhaps a pharmaceutical company that's considering what to do next. It's a partnership. And in fact, I had the opportunity to inspire the GOG Partners organization. It's a nonprofit foundation founded in 2010 to run many of the studies, and I continue to be the vice president of that and director of that. My day job is at Florida Cancer Specialists and Research Institute. Most patients are treated in the community where they live, and that's the way it should be. Florida Cancer Specialists and Research Institute is the dominant provider of cancer care in Florida. And we have research, think of this, we have research at 32 sites, 32 locations. My life's mission is not only to work with you, but also to work with locations to bring the research to the patient so the patient does not have to travel. And that's what I want to do, right? I want to be treated for whatever malady I'm afflicted with where I live, and I want the highest level of care like you do. So I'm the medical director of late phase clinical research at Florida Cancer Specialists. My home is in West Palm Beach. I grew up in Arizona and I used to live in California. If you haven't figured it out, I like warm weather. These are my disclosures. This is my message. I'm not getting paid for this, and I don't want to get paid for this. And the drug companies are not involved in this message. Okay. So I'm going to start generally and broadly. How do people, we're in the people business, survive cancer? Because half of us at least are going to get it. And so how do you not die from it, even though you might get it? Picking your doctor. The most important opportunity when you have a serious illness is picking your physician. And you should pick the best doctor you have. It's not always easy. And I told you that location is important, but that's in Florida, and Florida Cancer Specialists and Research Institute, like Texas Oncology is another example, is pretty good at making sure that the playing field is level, but there are other settings that it's not. And just because it's a university doesn't necessarily mean that they are providing the best care. It's a sign on the wall. And logos don't treat patients, doctors do. So that's the most important decision, because when you pick a physician, the physician recommends a treatment, and you're unlikely, at least you and Google or ChatGPT, to figure out what the right treatment is. You have to work with your doctor. You know, we used to identify cancer types under the microscope, and we still do a little bit, but that's not the way we talk. It's the genes that drive the cancer. So we don't say that, oh, a patient has endometrial cancer and then stop. We say that the patient has endometrial cancer, this mismatch repair proficient HER2 negative, as an example. So we have to learn that language. It's not that complicated. It sounds complicated, but in whatever cancer type, and Professor Matulonis did a nice job. Folate receptor alpha is one of those, and certainly BRCA mutation in ovarian cancer, and HRD and HER2. And it's really not a big lexicon. It's a language, but it's a whole lot easier than Chinese. I just got back from Taiwan day before yesterday, actually yesterday. The next thing in surviving cancer is access to clinical trials. If your doctor does not have access to clinical trials, you have violated decision number one. And if your doctor says, well, I don't have that opportunity, or my hospital, to run, because you can't receive the cutting edge treatments that you need or deserve without a clinical trial. And again, that's what I do here in Florida, 32 locations. And we don't have a big presence in the Fort Lauderdale, Broward County, because they don't need us, or in Dade County, Miami, because they don't need us. But in the rest of the state, the Tampa, the Orlandos, the Jacksonvilles, and in between, they do. And that's why I do what I do. So I think all of you know surgery is a good option. The way we do surgery today, we do it minimally invasive, laparoscopic, or we have a device called the Da Vinci robot. And if a person has uterine or endometrial cancer, they should have hysterectomy, even if it's metastatic, because the cancer is going to bleed. And if you have a cervical cancer that's early, the woman should have a hysterectomy, or even a more extensive hysterectomy. Generally, it's staged, the lymph nodes are biopsied. It's pretty straightforward, and that's important. Radiation still has value. Radiation can be beam. It's a beam energy in an area, generally in the pelvis. You can't in the pelvis, okay? But you can also put radiation somewhere, like in the vagina or in the cervix. That's called brachytherapy. Now we have what we call systemic therapy. And systemic therapy traditionally has been chemotherapy, sort of mischaracterized as poison. It's selectively poisonous, selectively toxic to the cancer. doesn't kill the body, it kills the cancer. There are some side effects. The reason the hair falls out is because it's rapidly dividing. The reason it preferentially kills the cancer because it's rapidly dividing. We have another opportunity. The blood vessels, the the blood vessels that feed the cancer can be interrupted. There's an antibody that we helped develop called vedotin, FDA approved in cervical cancer and maybe someday in endometrial and also approved in ovary. Immunotherapy is a big deal, and we're not going to talk about it. The two big medications, immunotherapy, pembrolizumab or Keytruda or dostarlimab, Jemperli, are really important, both in endometrium, both in cervical cancer. Both are used in the front line. It doesn't sort of Pepsi versus Coke. But patients with newly diagnosed serious cancer should get either one of these medications. And we don't need to talk about it because that's the bottom line. Okay? Newly diagnosed, advanced, serious cancers need chemotherapy and immunotherapy, whether or not you have cervical or endometrial cancer. Now, an oral medication called a PARP inhibitor, it's an ovarian cancer medication, but I've had the opportunity to work on all of these. And we're here today to talk about antibody-drug conjugates, play on words, the ABCs of ADCs. So antibodies are proteins in your body that stick to things, like bacteria, like viruses, and identify them for capture and destruction. And we can actually have an antibody bind to a target, what's called an antigen, that is overexpressed on the cancer cell and not on normal tissues. And we can attach a drug, a chemotherapy, a payload. It all means the same thing. And the antibody increases the drug concentration in the tumor based on the selective expression of the target or the antigen. And then the chemotherapy medication is internalized into the cell and kills the cell. And then when the cell dies, the payload chemotherapy is released into the tumor environment and kills the brother or the sister. It's pretty exciting. So it allows more dose intensity in the tumor, less dose intensity in the non-tumor. And that's what we call the therapeutic index. And that's why this has been transformational. So antibody-drug conjugates, very exciting, binds to the tumor, gets inside the cancer cell, and then has a bystander effect. This is fundamental. You don't need a PhD, ChatGPT or Dr. Google to help you understand this. This is, I'm going to go back a couple slides. This is the 5th generation of cancer treatment. Surgery and radiation is still important, okay? So we're a partnership. I already told you that. We have patients, providers, sponsors. The GOG Foundation is the opportunity to bring studies, but you still need a patient. You got lots of those. And you still need a doctor, although not all doctors do research. But it takes the trilogy of a study, a patient, and a physician to get everything together to bring the patient the best treatment at the best time, okay? So antibody-drug conjugates are a big deal. And the biomarkers, the targets for the antibody, there's 7 of them. And Dr. Matulonis talked a little bit about HER2. It's just one of the targets. It's one of the places where the antibody sticks to. We have several others. She also talked about Mirvetuximab here in ovarian cancer. I'm going to talk about 2 others, but we've been working on this for 30 years, and we understand how they can help patients live longer and live better, and we also understand the side effects. So the newest one she said is HER2. The genes can actually be mutated and turned on. They can be duplicated, but really if you just measure the protein that the antibody sticks to, you can create an opportunity for success and survival. And you can see, and she mentioned, not very common in ovarian cancer, but big, big numbers in endometrial cancer. Okay, so when a woman has endometrial cancer, it's not just under the microscope. What's the HER2 thing? Because at least 40-ish% is going to be positive, and that's an opportunity for an antibody-drug conjugate. So these are the three. She talked about Mirvetuximab. I'm pretty simple. I just call it Mirv. And it's against folate receptor. Tisotumab vedotin, simple, TV. It's against tissue factor. We don't need to measure this because it's so high. Mirv, we have to measure it. And then HER2, trastuzumab deruxtecan, we have to measure it. So sometimes you have to measure the target, sometimes you don't. Ideally, the tumor-specific target is so high, you don't need to measure it because all the tumors have it. But on the other hand, if it's not that high, we can measure it. Pretty simple. We do a biopsy, and then ultimately we can give it to give the patient the best chance. So I'm going to start a little bit about tissue factor. It turns out that patients with cervical cancer are at risk for blood clots. Sorry. And bleeding. Sorry. And part of that is because they have the blood clotting cascade activated or dysfunctional. So if it's active, if it works too well, it's blood clot. If it doesn't work enough, it's bleeding. So we can attack that with an antibody-drug conjugate called Tisotumab vedotin. And what we do is we do a randomized phase 3 trial. So a patient could have had access to this medication years before it was approved. Okay. Now it was a randomized trial of patients with, recurrent cervical cancer, and you got the Tisotumab vedotin tissue factor antibody-drug conjugate versus physician's choice chemotherapy. You say, I only got a 1-to-1 randomization, I only 50% chance. Well, I'm here to report, Bradley Monk reporting, that on a clinical trial, patients treated with standard of care do better than if they weren't. How's that possible? They're getting standard of care. Because in a clinical trial, you are monitored more closely. Every T is crossed. Every I is dotted. Every laboratory test is ordered. Every CT scan is reread. So even if you don't get Tisotumab vedotin, you still get this, which is very exciting because you get a concierge, somebody you can call right here next door. I got 3 CRCs on the phone right now, mission control for clinical trials here in West Palm Beach. So we did this study. And we do these curves, and if you're not familiar with them, I'll explain them to you. So in the beginning, 100% everyone has not had an event, and the event could either be death or a progression-free survival could be recurrence. And this is time. So over time, things happen. The probability of living or progressing falls. And you can see this is the trajectory. And at 12 months, for example, 48% of the patients were alive if they were treated with Tisotumab vedotin cervical cancer versus 35% who were treated with investigator choice chemotherapy. So the delta there is 13%. You say, well, that's only the average. You're right, that's only the average, but that's the way that we express and communicate success. And if you really want to compare this curve to that curve, you can do a mathematical equation called a hazard ratio, and it's 70%, which if you subtract 70 from 100, that's 30. This curve is 30% better than that curve. So at any given time, you have a 30% better chance of being alive if you get this antibody-drug conjugate in the cervical cancer setting. And that's called clinical trial. And again, even if you get standard care, you do better because you have the FDA breathing down my neck, okay? It shrinks tumors. So what we do is here's 0, and we add up the tumor measurements, and this is what they see. And you can see that the tumor measurements, this is a % decrease, that this below the line is better than above the line, okay? And that shows compared to investigator choice chemotherapy. So you got tumor shrinkage, you got delaying progression, and most importantly, you have increased survival. And this tumor shrinkage, if it gets to 30%, we call it a response. Okay. So you can interrogate the response, and very low for investigator choice chemotherapy, 17.8%. That's not very high, but there are other benefits, because even if the tumor doesn't shrink, it stops growing, which can be beneficial. Now, all medications have side effects, and it's my job to make sure that patients have fewer side effects. And the 3 side effects of interest associated with tisotumab vedotin are eye. As it turns out, the toxin, the payload, it falls off in the eye. I don't know why. But if the chemotherapy falls off the back of the antibody, you get a red eye, okay? And I can help prevent that, and I can help treat that. And so we recommend that the patient go to the eye doctor every dose. And it's generally an optometrist, because we all have eye doctors, and I have an eye doctor, okay? And then because the chemotherapy payload is a tubulin inhibitor, she used that term. Tubulin is what pulls the cancer cells apart, makes them divide. And if you can't divide the cell, then they don't live. And tubulin inhibitors cause neurotoxicity, numbness, and tingling. And we talked about the bleeding issue, because we're targeting the clotting cascade. The other class of agents, she said, are topoisomerase inhibitors. Topoisomerase is a process necessary to synthesize DNA. If a dividing cancer cell can't make more DNA, can't make more chromosomes, it doesn't divide. So you got 2 targets: preventing the separation of the cancer cells during cell division, or interfering with DNA synthesis. So HER2 has been a big deal. There are lots of ways to attack it. This is just a historical, and you can have these slides, and they'll be available to you. But we did a study in all tumor types. HER2, when it's overexpressed, is it possible that it works for every cancer type, every one, as long as you have the target? That's what we call pan-tumor indication. Pan-tumor means it doesn't matter if it's a pancreatic cancer or whatever type of cancer, skin cancer, or biliary tract. And this pan-tumor study included a lot of GYN. Why? Because HER2 is present in a lot of GYN, the least in ovarian and big time in endometrial cancer. And so this is a topoisomerase. So this is the linker payload, is the molecule that causes DNA to be synthesized. You can't make DNA, you can't divide. If you can't divide, then the cancer cell dies. And the antibody, they can engineer these. It's just a human antibody, and they put on the tips that it binds to HER2. And so the amount of expression matters. If in cervical cancer cohort, and we just score the expression 1, 2, 3, 1 plus, 2 plus, 3 plus. If you got 3 plus, it shrinks the tumor 75% of the time. If it's endometrial, 3 plus shrinks at 85%. Those are big numbers. And this just happened in April 2024. Okay, this is science. And again, the point is, if you would have been at a clinical trial site, you could have got this medication 4 years ago, or 3 years ago, or 2 years ago, because it was only in the standard of care 1 year ago. Pretty exciting, okay? Now, Professor Matulonis talked about interstitial lung disease. That's lung inflammation. So here, in the eye, tisotumab vedotin, it falls off, the chemotherapy. Well, here, it sticks to the lung tissue, and it causes lung inflammation. If it causes lung inflammation, you can't breathe. It's just like COVID. And on the X-ray, it looks like COVID, the pneumonia-like findings. And so we monitor for that. We're very sensitive about preventing nausea. We all hate it, so we give maximal nausea. She talked about giving growth factors. We can give medications that stimulate the bone marrow to make more white cells and platelets. The problem is that when you do that, the bone marrow is really cranking. And when your bone marrow is cranking, your bones hurt. So it's not perfect. We can work on, diarrhea. And when we give cancer treatments that work, they wear you down a little bit, fatigue. And what we can do is we can stop, let the recover, and we start again, lower dose. So many of these medications have multiple doses. Patient says, oh, is it going to work if we lower the dose? Yeah, this is what we always do. And the good news is it's working, and we're going to keep you on it because we can do a dose reduction. So again, we got 7 drugs that are pan-tumor. HER2 happened last April, and I'm very excited about it. The newest, and she talked about the newest targets TROP-2. So we talked about folate receptor alpha, we talked about tissue factor, we talked about HER2. Monk, what are you excited about? Well, I'm excited about TROP-2, and I'm excited because in our tumors, it's highly expressed, and we got a pretty exciting antibody-drug conjugate against TROP-2. And so these are the medications that we use in research today, over and over again. The antibody sesutecan, the payload trumatican, we abbreviated SAC-TMT, pretty exciting. And this study is in cervical cancer. We're doing it versus physician's choice chemotherapy again, but this time you can get TV. The slide doesn't, actually, this is the endometrial trial, sorry. So it's after failing immunotherapy, and in cervical cancer, it's versus Tisotumab vedotin TV. The study that I'm most interested in right now is that if you get newly diagnosed endometrial cancer, okay, if you get newly diagnosed endometrial cancer and you have non-MSI high where immune therapy doesn't work that well, you can get your carboplatin paclitaxel immunotherapy, and then in the maintenance phase, get the antibody-drug conjugate added to it. It's open today. So what would happen is you're diagnosed with stage 3 or 4 endometrial cancer, and your doctor is going to say, look, the standard treatment is carboplatin paclitaxel and pembrolizumab, but your molecular profiling says it's going to work, but just a little bit. And so now you can go on this study, a GOG study, a European study, a Merck trial, it's all the same study, and you can get randomized in the maintenance phase because it's 6 doses of chemotherapy with pembrolizumab and then maintenance pembrolizumab or Keytruda for 2 years. In the maintenance phase, you can get sacituzumab trumatican, TROP-2. It's a no-brainer. It is a no-brainer because in this setting, although this treatment is decent, it is not good enough. And you can get this treatment today if you have stage 3, 4 newly diagnosed endometrial cancer, okay? And if you don't get randomized to it, you still get all of the bells and whistles, the labs on time, CT scans on time, double checked, triple checked, and you get a concierge, someone that actually answers the phone. My father, before he died, I said, Dad, you should call your doctor to see really my doctor's going to answer. Well, if you're on a clinical trial, we do answer. And so there are lots of advantages to being on a clinical trial. Now, the side effect of these TROP-2 ADCs, we talked about eye, we talked about lung inflammation. When you use a TROP-2 antibody-drug conjugate, like the one I just described, I'm concerned about oral mucositis, mouth sores. And what we can do is we can use cooling measures to cause vasoconstriction so the chemotherapy antibody-drug conjugate doesn't get to the tissue. And you see that. You can get a cold cap so the hair doesn't fall out. You can get gloves so you get numbness and tingling on your fingers and toes. Well, with TROP-2, you can get this device. It's a mouthpiece, and you put it in the freezer, and it freezes, and then you put it in your mouth for 30 to 45 minutes while it thaws. You say, well, why don't I just chew ice chips? Well, the ice chips are not evenly distributed. The infusion center doesn't have ice chips. I have cold sensitivity on my teeth and I use Sensodyne toothpaste and I still have teeth that hurt with cold. Okay. This defeats all of that and helps patients do better with mouth sores. So again, I'm committed to developing new medications, getting them into clinical trials, getting them into patients, helping them live longer, helping them live better, but defeating the side effects. Patients have to live longer, but also live better. So pick the right doctor, know the molecular signature of your tumor, and you have to have access to clinical trials. And if you don't, then you go back to number one. Thank you for having me today.